Thanks everybody for joining the second episode of the webinar series, Building an Affordable and Sustainable Health Insurance Plan You Can Brag About. I'm your general contractor and host, Mike Krupa. Quick background on me is I'm a former home remodeler, turned actuary, turned benefits advisor, and I am really on a mission to help employers offer better benefits at lower costs. Last week, we did a deep dive on the Remodel Health Plans program, and we're going to start with a brief refresher. But before I introduce our guest, Alex Lickerman, the founder of ImagineMD, to help with today's topic. So I'll start with that refresher first. The topic of today is purchasing primary care like a gym membership. If you have any questions, please enter them in to the question box. And both Alex and I will stick around for 15 minutes afterwards to answer those questions. And if we have time to do that during the presentation, we will do that as well. All right, at the end of this series, we are going to review in detail how one local employer created a big win out of a 35% increase in their overall health plan. But before that, today and the next three episodes, we are going to focus on different solution partners that we actually implemented for this employer to create that big win. And so today we're talking about primary care, and we're going to talk about prescription drugs. We're going to talk about primary care again in September. And finally, in October, we'll reveal a lot of the details of our case study. Just as a reminder, this overall series is really constructed to teach three things. First, how to avoid a surprise health insurance renewal. And we focused on a lot of that in the last episode, and how building a long-term strategy can help get us there. But in addition, we're going to show you how self-funding can lower your costs. And today's focus is really going to be about offering a benefit that can make your overall employee benefits package much more competitive. So for most employers, their health plan looks like the one on the left. And for the case study that we're going to review, I can tell you it sure did. They were offering $6,000 deductible health plans to their employees. And so that was my bathroom a couple of years ago. Things were falling apart. The shower was leaking. We didn't have a whole lot of functional space at all. And as I started to take apart the old bathroom, I started to understand the problems I was having and why I was having it. And then I started a plan for the new bathroom on how to make it better. And the picture on the right is the final product. And most importantly, the customer, in this case, my wife, was extremely happy with the final product. And that's one of the things I want to stress throughout this entire series, is that there's a lot of remodeling that can be done on your health plan, but at the end of the day, the customer, which is you and your employees, they need to love it. Second, we talked about this a lot last time, but if you want to avoid being surprised by your health insurance renewal, the first thing you got to do is stop making one-year decisions, and that means setting up a long-term plan. And lastly is you don't have to remodel your health plan all at once. By the end of the series, we're going to show you one employer and a really good destination, but every employer is different in terms of how they get there. So here's a quick refresher of the Remodel Healthcare program. There's three steps. First is you need to establish control. And if you're a fully insured employer on the phone, establishing control means a couple of things. It means starting to look at the data within your health plan, but more importantly, starting to develop a long-term strategy. If you're thinking in one-year decisions, you're probably going to get the same results that you've gotten in the past. But as you start to plan out multiple years into the future, that's when things start to change. And ultimately, moving into a self-funded health plan is going to allow you to do the next couple of steps, which is align with partners that have your best interests in mind, partners like ImagineMD, who's on the phone today, and then rewarding your members for making good healthcare decisions. That's how we get the customers or your employees to love the health plan that they're in. We got to reward them for making the right healthcare decisions. So with that, Alex, I'm going to go ahead and stop sharing the screen right now, and it's just you and me. I'm going to have you do a quick introduction of yourself.
Sure. So my name is Alex Lickerman. I am the founder and chief medical officer of ImagineMD, which is a direct primary care medical practice headquartered in Chicago with 5 offices in total around the Chicagoland area. We opened in 2016, January 2016, and currently we're servicing 14 employers in the Chicagoland area who have done what Mike is talking about, remodeled their healthcare plans.
All right, great. So let's dig in. I think for most employers on the phone, they may not even know what direct primary care is. So can you help just define exactly what it is we're talking about today?
Yeah, so direct primary care is 2 things really, and there's 2 ways to think about it. The first way I think about it most simply and most basically is that direct primary care is a new model of payment for primary care. So in the traditional fee-for-service world, which is what everyone's used to, you go to see your primary care doctor and that visit is a service for which you pay a fee. So if you're fully insured, typically the insurance company is covering the majority of that cost, but you usually have a copay, a co-insurance, and a deductible that often may contribute to that. And you only pay for, you only have a payment when you get a service. So there's a lot of problems with the fee-for-service world, which we can talk about if that becomes relevant. But the difference with direct primary care is that it's a membership model. And the title of your talk was great, right? Because this is like paying for primary care as if it were a gym membership. And that's my favorite analogy. In fact, I think you stole it from me, but that's okay. So the idea here is you pay a fixed monthly membership fee. It's a per employee, or a per member, I should say, per month fee. And that gives you everything we do. So there are no co-pays, no extra payments per visit, per service. The idea is you pay that fee to ImagineMD, and then we take care of you. And everything, just about everything within our 4 walls is covered by that fee. So you don't have to worry about that. And this frees us to actually design a primary care practice the way it really should be designed. And the reason for the direct primary care model, the membership model, is so that we can change the way we practice medicine. And while different direct primary care offices will do this differently, they all have some form of, a membership fee. They all do it in order to actually change the way they practice. And so the way it's enabled us to change the way we practice is the following. We offer new patient appointments for 2 hours. If you're an individual signing up, not a part of a group practice, we set that up within the first week of you joining. If you are part of an employer group and you have actually hired us to care for all your employees, typically in the plans that Mike designs, and the way we like it designed is the employer covers our membership fee for the employees. So from the employee perspective, visits to our doctors are at 0 cost. And that first 2-hour initial appointment is usually arranged within the first month to occur within the first 3 months. Of course, we prioritize people who have acute issues going on. Return appointments are scheduled for an hour, and they're scheduled typically on the same day a patient calls or the next day a patient calls. And then perhaps most importantly, we give all of our employee members 24/7 access directly to their own physicians. Every physician in our company has 2 phone numbers. They have a direct phone number and an emergency phone number. That emergency phone number enables you to reach your physician literally 24/7, 365 days a year, except when your physician's on vacation, during which one of their colleagues is covering for them. And so we really bring back the relationship between the patient and the doctor so that the patient knows to call their primary care doctor at ImagineMD for everything that's going on with them, especially and including things that might be emergencies. So in a nutshell, that's how it works.
Yeah, so sounds great. So let me maybe back up for a second. What problem does this solve? What problem does direct primary care solve for an employer? Because I can tell you some of the things that I've been hearing from employers recently, but I'd love to hear from you.
Sure. At its core, we solve 2 problems. The first problem we solve is the problem of medical care and medical access for the employees, right? So the reason we exist, the main reason I founded ImagineMD, was to provide primary care services the way it really should be provided. The problem with the current healthcare system in the fee-for-service world is the lack of access. So when you call a primary care doctor now in the fee-for-service world, on average, it will take 20 days to get an appointment. And when you get in for that appointment, on average, you will spend 16 and a half minutes with that primary care doctor. I cannot stress how important and limiting this characteristic of the fee-for-service system is, right? It takes more than 15 or 16 minutes to change your oil in your car, right? If you have a complex medical history, if you have an unknown medical problem, chronic medical conditions, if you struggle with anxiety, depression, which is now epidemic in our society, 16 and a half minutes is completely inadequate to manage those problems. Doctors, primary care doctors need more time. Time is the secret sauce. We want to get patients in quickly, and we want to spend adequate time with them so we can think about their medical problem, we can do reading in the medical literature, we can consult our colleagues, we can actually practice at the top of our training, the top of our license, because when we have that opportunity to do that, statistics will tell you we can handle about 80% of every person's lifetime medical needs. 80% in primary care means 80% of your care is happening in the least expensive part of the healthcare system. So again, the first problem, the most important problem we solve is lack of access and lack of quality of care. It makes a big, big difference. The
I was
second
talking to an employer yesterday, Alex, who was telling me the exact same thing. And I'm hearing this from employers on their employees all over the place, is that people are trying to get into their primary care doctor, and it could be September before the primary care doctor can actually see them. And I think what's important to know for the audience is, if you have anything like complex or semi-complex going on, when we're talking about how this could impact your health plan overall, not being able to nip that in the bud right away, that could lead to, a potential large claim down the line or a higher cost event that doesn't need to be there.
Well, that's the second problem we solve. And I was going to say, the way they talk about in the legal system, justice delayed is justice denied. Care delayed in the medical system is often care denied. And I can't tell you how many times we have seen opportunities to interrupt what could become a really serious big problem requiring a hospitalization or even a surgery. When they get to us in time and we make the diagnosis early, that often becomes a claim that never occurred, right? So how do we, the second problem we solve is we save employers money. And how do we do that? There's two basic important ways to do that. The first way is, if you look at the analysis of the companies we care for, and we've done this analysis where we compare the number of medical claims in the system for those who choose the ImagineMD plan versus what's often a side-by-side plan where they don't have an ImagineMD direct primary care physician, but they're otherwise in the same plan. It's typically, we use reference-based pricing, which if you haven't discussed with this group, you can explain that. We have about half of the referrals outside of our four walls, outside of primary care, that other primary care doctors do. And it's because we have so much more time to spend with them and they have so much better access with us that we can take care of a lot of the problems that primary care is trained to take care of, but that other primary care doctors in the fee-for-service system don't have time to take care of, or they can't get in to see them in time to take care of. So we reduce costs by reducing claims, one. But that's not even the biggest bucket. The biggest bucket is when we do need to refer out of our four walls for whatever a patient may need, an MRI, referral to a surgeon, even a surgery. We follow the plan design that you and consultants like you have created that hands us tools to send people where there is transparent, reasonably priced, reference-based pricing levels of reimbursement, so that the MRIs we can get, along with the tools you've designed, is for $350 versus $3,500 at, say, a large medical center. So we've been doing this in the Chicagoland area for 8 years. We know where the high quality providers are who accept the reference-based pricing reimbursement level. We just send them there. So we do an enormous amount of what we call steerage behind the scenes. The analogy I use is we're like a duck gliding across a pond that looks to be very smooth and easily sailing, but underneath we are paddling like mad. We take on that work to steer your employees to high quality providers who actually build the plans that people like Mike build, where the reimbursement level is a reference of Medicare and not, say, Blue Cross Blue Shield that's maybe 300 to 600% of Medicare. So our mission and our value add and the problems we solve is we dramatically improve the quality and access to care. We actually turn healthcare benefit for employees into an actual benefit they're excited about. And then we save the plan money. We reduce the expensive plans by as much as 30 to 34%, even with our fees included.
Yep. Yeah. And I would second that. We're going to talk about the steerage component a whole lot more in a later episode with your partner, Rhea Campbell. Um, you know, we've been reviewing, obviously, after getting quite a bit of data from our employers that are utilizing direct primary care. We've been digging into those details on specialist visits, emergency room visits, urgent care visits. And we have noticed exactly what you're talking about, Alex, is that when we compare employees that have direct primary care versus employees that are in the typical fee-for-service environment, which is what everybody is used to with like a Blue Cross United or Aetna or Cigna, there's a significant reduction in the amount of people using the ER, the amount of people using the urgent care, and specialists as well. So, for the audience, it's important to understand that Alex is saying that, but we are actually seeing that in the data on our own clients as well.
It's not a hard story to understand. I mean, I used to practice the fee-for-service model, and the rate limiting step for me was time, right? So when I had literally 15 minutes to spend with the patient and they had a problem that I knew how to take care of, like migraine headaches, but they also had come in with an ankle sprain, a rash, and a urinary tract infection, my 15 minutes were used up. And they're saying, oh, and by the way, I'm having headaches. I'm like, well, I'm looking at my watch. I'm going to send you to a neurologist because I can take care of this. I don't have time, and I don't want you to have to wait. And then the other issue for us is, all of that unnecessary urgent care and ER visit care. When a patient has direct, immediate access to their primary care physician anytime, day or night, that's how we make a difference in preventing all that unnecessary utilization of the most expensive part of the healthcare system, urgent care and ER, because often patients don't need that. They just go there because they can't get to their primary care doctors. Well, with direct primary care in our system, at least in ImagineMD, they can always get to us.
Yeah, I think about one of the things you often say about emergency rooms is that people that think they need to go to the emergency room often don't, and people that don't think they need to go to the emergency room often do. And I think, everybody would appreciate having their doctor basically on call in the middle of the night. I mean, it comes up with children all the time.
All the time. And the way I talk about this is, imagine if you had a sister or a brother who was a physician who you felt comfortable calling anytime, day or night with any issue, and you get concerned enough that you think you might need to go to the ER, you're calling your sister or your brother. Well, that's us. And so we want to talk to you because we can often sort out on the phone whether what's going on could be an emergency, and so you're going to have to go, or it's clearly not an emergency, which is usually the case. And so, I mean, what's the average cost of an ER visit in Illinois? I think it's something like $2,500. We prevent those all day long because they're just not necessary.
Yeah, no, it's very, very telling story. Let's maybe dig into a couple of other things. When I think about the remodel health process, right, we got control, we got align, we got reward. Align, what we talked about a lot during the last episode, a big focus is aligning with health plan partners that have the employer's best interest in mind. You mentioned you get paid a membership fee. Do you get paid anything else outside of a membership fee?
We only make our revenue from the membership fee, and we do that for a very specific reason, because part of what's wrong with the fee-for-service system is the way incentives are aligned. They're misaligned, right? So if you are being paid for a service you perform, you are by definition incentivized to perform more services. So for example, there's a lot of gray in medicine, right? And so when a patient calls up and they have an issue that they're talking about, often there is a choice whether we need to bring them into the office to be seen or we don't. We can just handle it on the phone. And if you are in the fee-for-service world, you can't bill, you certainly can't bill significantly for a phone visit. But so you are incentivized to bring people in. And so and I believe most doctors really are kind of pure-hearted about this, it's hard not to be influenced by that incentive to think to yourself, well, if I bring them in, I'll be absolutely sure I know what's going on. And oh, by the way, I can bill for this. Well, our incentive is not to bring people in or to do more medicine or less medicine. Our incentive is just to take really good care of people so they want to stay with us and keep paying our membership fee. So the only incentives that drive our medical decision-making is what is right medically for the patient. And that's what you want. You don't want a doctor to be incentivized to do less to you, and you don't want a doctor to be incentivized to do more to you by the way they're reimbursed. And that's what the fee-for-service system does. That's what the old HMO systems did, and we are not an HMO. I think that's where you're going with this. You know, the thing about HMOs that is different from us is while this is capitated care, it's a membership model. Our fees are not at risk based on utilization, right? The old HMO model was you give the HMO gives the doctor's office, here's a pile of cash. You use this pile of cash to take care of our members, and anything you have left over at the end, you get to keep. Well, that incentivizes me to do less medicine, to not order that MRI when maybe I need to, and that's a bad idea. So we reject that model. We do not put our fees at risk in any way simply because of how it will motivate us to practice medicine in the wrong way.
Yeah, those incentives are key when we're talking about remodeling a health plan. When you figure out what the incentive is, you can pretty quickly figure out why things are happening the way that they are. And it's not just on the primary care, it's in all aspects of the health plan. You know, the other component of the remodel health plans that this really brings to light here is rewarding employees for making good healthcare decisions. And the big reward here, just to kind of frame up how we structure these types of plans when we put these in place, is we usually offer direct primary care as a plan option alongside another plan, because we know not everybody is going to want to necessarily change their primary care provider. So we give them a choice, and then we reward them for that choice. We know that model produces lower costs over time. So we reward them in a couple of ways. We reward them by, one, we have the employer pay that membership fee on behalf of the employee. So it's free to them. Every time they go in to see their primary care doctor, it's free. But then in addition to that, we typically incentivize employees to take this plan through a better plan design and through payroll deductions, so lower employee contributions. So those are some of the ways as we structure these types of plans, how we are rewarding people for making the right decisions. And if they want to still stick with their primary care provider that they have today, because you will have some that will do that, we offer them another plan, but they're disincentivized to take that plan. And so that's just some of the ways that this remodel health plan program fits around direct primary care. Alex, we got a few minutes here. I got a couple other questions for you. Who's a good fit for direct primary care?
Right. So direct primary care makes zero sense for people who are still fully insured, because we are a fee on top of your insurance premium, and we cannot, while we can definitely provide higher quality care for your members, we can't save you a dime. We'll cost you money, because when we refer out, we are by definition referring into a network that's going to be, you know, the fixed cost. You're not paying those costs, you're paying premiums. So you have to have some form of self-funding to do that. And beyond that, it's really anybody who wants to improve the quality of care and access that their employees have to care, as well as actually reduce their medical expenses. I mean, you know, of course, when you go self-funded, it's not just that you're going to reduce cost of care and cost to your health plan, you're going to get control of it, right? You get to decide how the plan is designed. You get to decide how to provide really high quality care to your employees. So we're looking for employers who are willing to try something new and really want to have really turn healthcare benefits from this thing that employees dread and complain about and make them angry, to actually a real benefit where it's a way of not only attracting but retaining the best talent. Currently, we are finding the people who are most interested in this model of care actually are blue collar companies. My suspicion about this is because white collar companies, they have a greater capacity to absorb the pain of these increases year over year, and they're offloading the increased cost on their employees more and more, but their employees are highly compensated. But even them, at some point, they're going to say, no more, this is just too much. And so it really does work for everybody.
Last question for you here before we move on is just, when you are hearing from employers, I'm sure you hear about objections, right? Because this is new. What are the most common objections that you hear?
You know, what's funny is every single time we have been to a pitch meeting with an employer, by the end of the meeting, someone in the room says, why wouldn't we do this? And yet then a lot of times they don't. And so I think there's a couple of things. One is, I think it is fear of change, fear of the unknown, fear of being the first, fear of like, well, healthcare is bewilderingly complex. If you're a business owner, you know your business, you don't know healthcare. It takes an enormous amount of emotional energy to learn what healthcare is about and why programs like Mike's Remodel Healthcare are so superior to the status quo. But the status quo is comforting. You know it and it works. It's expensive and it's killing you, but it's comforting. And I think people are just reluctant to change in general. And then I think the other barrier is the perception among leadership about how their employees are going to respond to this. They're very almost afraid of their employees because in the realm of healthcare benefits, it's been bad news year after year after year, and they know that their employees themselves are reluctant to change and are suspicious of things. It takes courage to recognize, this really is a benefit. Employees are really going to like it. It's a hard thing to explain. It's a hard thing to understand until you've experienced just how different life is in a direct primary care plan. But this is why, by the way, in the second year of our plans, no one leaves our plans, and we have upwards of 30% of people in the alternative plan joining our plans because that water cooler talk circulates. So I think the answer is an employer who really wants to save money and improve the quality of health of their employees has to be willing to dig in and learn enough to understand why the remodel health plan is superior and how it works, and then have the courage to try something different. And people tend to change only when pain is great enough to make them change. So those premiums are just maybe going to have to be jacked up more and more and more for you to finally say, look, we've had enough. We've got to try something different. And then usually what ends up happening is, as is often the case, you kick yourself for having waited so long once you actually take that leap and cross that line.
Yeah, I see that as well. The pain thing is really, really interesting to me. It is. It's always. It's typically an employer. I mean, heck, the case study we're going to talk about, right? We had that client for 3 years. They remained fully insured before they actually went self-funded. And what caused them to make the change? Well, a 35% increase in their fully insured premium. So totally agree with that. Alex, can you see the screen again?
I can.
All right, perfect. So we're here at the end of time, but we're going to stick around for questions. This is just two ways. If you guys are interested in seeing some content, I put a lot of content out there, a lot of videos, things like this webinar here. Connect with me on LinkedIn or subscribe to my YouTube channel where you're going to see all of that content, and I hope to provide you with some value. Last, we'll leave it for some questions. If you feel like you're ready to have an initial discussion, use this QR code to schedule a meeting with me. One thing I can promise you is that it'll be a non-salesy meeting. I'm a former home remodeler, former actuary, so I'm not even really that good at sales. But if you're interested in talking, please reach out, and I'd love to give you some advice. Outside of that, I did see a couple of questions come in, so I'm gonna start with those. One is, Alex, does this replace traditional insurance?
Direct primary care does not replace traditional insurance. Direct primary care we replace your primary care doctors, but the remodel health plan does replace traditional insurance, and you embed us into that remodel health plan where we are sort of the captain of the ship. So we actually make sure to use the tools that Mike creates in the plan. That replaces your traditional insurance. Yes. Yeah.
So you still, you need to go to a specialist. You need to go to a hospital. There is still insurance for that. And often that's a PPO network. Sometimes it's not. But yeah, there's just this one component. So great question, but no, the insurance actually stays very similar to what it is today. Maybe next one here. Let me take a look at this. Yep. Okay. Do you see employers offering this as a full replacement? Like one plan, direct primary care, one plan only, and that's it?
We do, I think, have one, maybe two employers who have done that. The challenge is forcing people to switch their primary care doctors often doesn't go well. On the other hand, employees often have the option not to choose their employer's insurance plan. So we have seen it. That's in groups typically where the community in the employer is really strong, where the leadership and the employers really have a good relationship, where the employers trust the leaders, and they come in, and we'll come in and we talk to the employees. We come into pre-open enrollment meetings, we come into open enrollment meetings to help explain this. And so I think that it is done. It's not the norm, but it can be done.
Yeah, and I can second that. I do have two clients that currently have full replacement, and the first client that decided to do that, they had a lot of meetings with their employees and their spouses to get them on board with making this change, really getting their buy-in overall, and they highly incented employees to take this. They actually dropped payroll contributions overall completely. So there are employers that do it, but I would just say to the employers on the phone, the typical way that we find the most success with structuring this, unless you can do a full replacement, is to offer this alongside another traditional insurance option. All right. The next question, Alex, I think I'll take this one. Can multi-state employers offer direct primary care? So I think the short answer to that is yes, you can. And there are employers that are actually doing this right now. When I think about the demographics that make up a good candidate for direct primary care, it's definitely having a centralish location somewhere, because you want your employees to be able to have a decent driving distance to see their primary care physician. The thing about multi-state employers is that, I'll just say, direct primary care is not everywhere yet. And so there can be some more challenges by doing that. And typically when we're talking to clients about implementing direct primary care, and if they want to do it in multiple states, what we'll look for is just what I talked about, is that pocket of people that could be around an actual clinic. But that's why it's also important to offer, a traditional plan alongside it, typically. And then the other thing I'll add here is that, one approach that we've seen with some employers is to pilot direct primary care, maybe with one of their states. Alex, you mentioned a lot of the fear of the unknown, the fear of the change. That's a real thing. And so that's a consideration for employers, is that, hey, look, if you want to dip your toe in the water, one consideration is, think about one of your states where there's a big location, and maybe offer this as a second option just within that state, and use that as a case study as you start to roll this out potentially to other states. So that's always an option as well.